So, very good morning, students. Sorry there was a delay in coming out with the trimethoprim sulfonamide combinations because we have been involved in the contact tracing of the COVID patients. So, time to time we are called for making the relevant phone calls and going for contact tracing. So, sorry students for a little delay in this part 2, and today we are going to read about the first synergistic combination among the antibiotics, and that is sulfonamide with trimethoprim, and the name of the drug is cotrimoxazole. So what is cotrimoxazole? It is nothing but a fixed combination of sulfonamide with trimethoprim. And which is the sulfonamide which is selected? It is sulfamethoxazole. Sulfamethoxazole, as you had read in the previous session, is an intermediately acting sulfonamide. It is combined with a drug which is trimethoprim, and this trimethoprim also is intermediate acting. So both of these drugs have a half-life of 10 to 11 hours, and that makes it very convenient for the patient to take it as a fixed dose. So that is why sulfamethoxazole is selected. Trimethoprim is a diaminopyridine, and it is a potent inhibitor of bacterial dihydrofolate reductase. I told you the second step in the conversion of dihydrofolic acid to tetrahydrofolic acid involves the enzyme dihydrofolate reductase of the bacteria. So trimethoprim is going to inhibit that second enzyme, and the first enzyme will be inhibited by sulfonamide, the second enzyme will be inhibited by trimethoprim, bringing about a term which is called sequential blockade. Trimethoprim exhibits an antibacterial spectrum very similar to the sulfonamides, and most often it is combined with sulfamethoxazole. I told you the reason is combination is a similar half-life of both the drugs. It is 20 to 44 fold more potent than sulfa because lesser dose is required, and may be used alone in the treatment of acute urinary tract infections, but it is usually combined with the sulfamethoxazole, and it can be used in the treatment of bacterial prostatitis. So that means it can be used alone also for the same. Now sulfonamides alone, students, are bacteriostatic, but when they are combined with the trimethoprim, the combination becomes bactericidal in nature, and it brings about complete suppression of the bacterial folic acid synthesis. So that is what it is. Sulfonamides inhibit dihydrothyroid synthetase, trimethoprim inhibits dihydrofolate reductase. As a result, there is complete suppression of tetrahydrofolate, and that is not able to participate in important functions of the bacteria, and hence that leads to bacterial cell death. Now this is very important, students, for understanding. We have already told you that this is a synergistic drug combination. Reason being because both the drugs, they cause a sequential blockade in the folic acid synthesis of the bacteria. What is the ratio in which it is combined? Sulfamethoxazole ratio is in the plasma, which is achieved is 20, and the trimethoprim is 1. So trimethoprim, I told you, is more potent than sulfamethoxazole. So doses required accordingly will be less for trimethoprim and more for sulfamethoxazole. Trimethoprim is also widely distributed in the body, and the ratio which is attained in the plasma for sulfamethoxazole and trimethoprim is 20:1. And if you want this ratio in the plasma, then the combination of the dosage which is there is 5:1, where 5 is for sulfamethoxazole and 1 is for trimethoprim, 5:1 ratio. So accordingly, if you are giving 400 milligrams sulfamethoxazole, then trimethoprim will be 80 milligrams. So 85s are 40. That is called the single strength tablet. And you can give a double strength tablet also, which will comprise of 160 milligram trimethoprim with 800 milligrams sulfamethoxazole, which is a double strength tablet. Students, this ratios are asked, both the ratio of the dose and the plasma concentration. And what do you mean by a single strength tablet? What do you mean by a double strength tablet? These questions are frequently asked in the examination. Now this is what I have told you. Sulfamethoxazole is a bacteriostatic antibiotic, and alone they will not be able to eradicate or kill number of bacteria, but once they are given along with together, then you can see there is complete suppression in the bacterial colonies, and they kind of have a very strong bactericidal action. The other mechanism which favors the combination of sulfamethoxazole with trimethoprim is the half-life suitability or the pharmacokinetic suitability, because you know these drugs, they have a similar half-life. So once the next dose of the patient comes, it comes at the same time. So that gives this combination an advantage. So that is why if you want to combine any drug with trimethoprim, the best sulfonamide which will be suitable as far as pharmacokinetics is concerned is sulfamethoxazole, and this is a synergistic action, students, as I explained you. Regarding the pharmacokinetics of this combination, it is more lipid soluble than sulfamethoxazole. It has a greater volume of distribution. We are talking about trimethoprim here. It can be administered orally, and exceptions involve intravenous use in patients with severe pneumonia caused by pneumocystitis jirovecii or pneumocystitis carinii, or to patients who cannot take the drug by mouth. So this combination can usually is given orally, both for the prophylaxis as well as treatment of pneumocystitis carinii or pneumocystitis jirovecii pneumonia in patients of AIDS, and it can be used intravenously also for the indication. This drug they concentrates in the acidic milieu of the prostatic fluids. That is why it can be used for prostatic infections, vaginal fluids, and it is also one of the good drugs for uncomplicated urinary tract infection. This is the spectrum of sulfamethoxazole and trimethoprim. Students, never forget that cotrimoxazole, the combination, is a drug of choice for patients who are having pneumocystitis jirovecii pneumonia. For prophylaxis also it is given if the CD4 counts fall below 200. For treatment also it can be given, although we have other drugs for the treatment for pneumocystitis jirovecii pneumonia in the form of clindamycin, in the form of pentamidine, but yes, this drug can also be given. So this is one of the opportunistic organisms which has limited treatment as far as possible. So for pneumocystitis carinii or pneumocystitis jirovecii pneumonia, we give cotrimoxazole. Now the other use of cotrimoxazole, the combination of trimethoprim and sulfamethoxazole, is for the treatment of prostatitis and for the treatment of urinary tract infections, and especially the uncomplicated urinary tract infections, not the complicated urinary tract infections, because complicated urinary tract infections we might have to give aminoglycosides or fluoroquinolones, but yes, for uncomplicated urinary tract infections, lower urinary tract infections, cystitis, etc., cotrimoxazole is preferred as a single dose, or it can be given in the dose for 3 days. The other organism which is susceptible to cotrimoxazole is Listeria monocytogenes, which is a gram-positive bacteria. It can cause meningitis, and ampicillin actually is a drug of choice for Listeria monocytogenes, but we can also give cotrimoxazole. And for GIT infections, earlier we were giving cotrimoxazole for the treatment of typhoid fever, but no longer now, because there has been presence of resistance for cotrimoxazole. Also, this drug may not be able to abolish the carrier state of Salmonella typhi, and cotrimoxazole is used in the treatment of Shigella dysentery and sometimes non-typhoid Salmonella. Because the sulfonamides have a good passage across the blood-brain barrier, they can be given for treatment of Haemophilus influenzae. This drug can cause pneumonia, this drug can cause meningitis, and it is also used as an alternative for erythromycin-like drugs, for macrolides, for Legionella pneumonia. And for Legionellosis, we have azithromycin, which is a drug of choice, but if that cannot be given, then cotrimoxazole becomes a reasonable alternative. So students, don't forget, out of this picture, for the spectrum of action, you must not forget forget the use of cotrimoxazole is its use in pneumocystitis jirovecii pneumonia in AIDS patient. Also, its use in urinary tract infections, uncomplicated urinary tract infections, because it assumes large concentrations in the prostatic fluid. It can be used for prostatic tract infections. For these two indications, it is not the drug of choice, but yes, it can be used. So this is about the antibacterial spectrum of cotrimoxazole. Now coming to uses with the doses, one double strength tablet, which is 800 milligram sulfamethoxazole and 160 milligram trimethoprim, is given every 12 hourly for treatment of urinary tract infection and prostatitis. One half of the regular tablet given 3 times weekly for many months may serve as prophylaxis in recurrent UTI for some women. So you know, prophylactic dose is always a lesser dose, less frequent dose. It can be used for recurrent urinary tract infections in some women, and it can also be used for eradication of the full-blown urinary tract infection. But I would repeat here, it is for lower urinary tract infections, cystitis-like conditions. One double strength tablet every 12 hours is effective for the treatment of susceptible strains of Shigella and Salmonella, although they are not the drugs of choice now, for the treatment of typhoid or Shigella. This is the indication for which they are the drugs of choice. High doses of the combination, that is in the range of 15 to 20 milligram per kg per day, have been used to eradicate for the treatment of infections caused by pneumocystitis jirovecii or pneumocystitis carinii pneumonia in patients of AIDS. It can also be the infection can also be prevented in immunosuppressed patients by one double strength tablet daily or 3 times weekly. So this is the prophylactic dose and this is for the treatment. Now coming to the adverse effects will be similar to what we had for sulfonamides. What are the adverse effects of sulfonamides? You can have some crystalluria. The most common side effect is of course unwanted skin reactions. Sulfonamides can precipitate hemolysis in the G6PD deficient individuals. They can cause drug fever. They can cause many other untoward reactions, and same reactions will be shared by the combination cotrimoxazole because it contains nothing but sulfamethoxazole. So there will be predictable effects of anti-folate drugs, especially on the humans also, because DHFRase is present in the humans also, and trimethoprim will inhibit the DHFRase of the mammalian cell. Although we say the concept of selective toxicity, but it is not absolute. So we are going to have signs and symptoms of folic acid deficiency in the form of megaloblastic anemia, leukopenias and granulocytopenia. As such, sulfonamides cause adverse effects on the bone marrow. So that is going to continue, and all other untoward effects associated with sulfonamides. Nausea, vomiting, as you say students, you write it for each and every drug, but here it is common. There is drug fever, renal damage, CNS disturbances can occur, and patients with AIDS and pneumocystitis pneumonia have a particular high frequency of untoward reactions with sulfonamides, especially the reactions which are related to the skin. They are more common in patients of AIDS. So there are these common side effects. Skin rash becomes very common. Hematologic toxicities become very, very common with cotrimoxazole. So which one of the following statements, students, about sulfonamide is false? Let us identify the false statement. Sulfonamides are anti-metabolites of GABA. If you see the E part, yes, they are. Sulfonamide crystalluria is most likely to occur at low urinary pH. Yes, it is more favored at acidic pH. That is why we say that the patient should have a neutral urine, or his urine should be alkalinized. There is a cross allergenicity which occurs between sulfonamides and thiazides. Yes, cross allergenicity occurs because thiazides also have the sulfa group. Not only the thiazide, say some of the loop diuretics, acetazolamide, which is a carbonic anhydrase inhibitor, all those drugs, you know, the blood sugar lowering drugs like sulfonylurea class, the protease inhibitors, all who have the sulfa group, the COX-2 inhibitors, they are going to have cross allergenicity with the sulfonamide. So this is a correct statement that it may occur. Dysfunction of the basal ganglia may occur in the newborn if sulfonamides are administered late in pregnancy. Definitely, because if they are administered late in pregnancy and towards term, the newborn will have unconjugated bilirubin crossing the blood-brain barrier, causing dysfunction of the basal ganglia. What sulfonamides are not? They are not inhibitors of bacterial dihydrofolate reductase, DHFRase. They are inhibitors of bacterial dihydropteroid synthetase. Remember this thing, they are not inhibitors of dihydrofolate reductase. reductase. The inhibitor of bacterial dihydrofolate reductase is trimethoprim, students, and not sulfonamide. So this is the false statement or the incorrect statement. The A part, that sulfonamides inhibit bacterial dihydrofolate reductase, is incorrect or false. Now next MCQ is, which one of the following adverse effects is most likely to occur with sulfonamide? So these all can happen with sulfonamides. We discussed that it can cause CNS side effects. It can cause connectors in the newborn. It can cause hematuria. It can cause renal damage. It can, or may Fanconi's amino aciduria syndrome. It I think does not cause that. That is caused by tetracyclines. Skin reactions. Now you have to see which are the adverse effects which can be caused by sulfonamide. Neurological side effects we agree, hematuria we can agree, connectors we agree, skin reactions we agree. But what is my question? Which one of the following adverse effects is most likely? So when the question is coming most likely, it means that skin reactions are the most likely untoward reactions. So this would be your answer. Which will be your answer? The occurrence of skin reactions, which I told you can range from a mild rash to morbilliform rash to dangerous Stevens-Johnson syndrome, exfoliative dermatitis, can occur with the sulfonamides, students. Now coming to the fill in the blanks. Sulfonamides used for burns dressing are which are the ones? It is, there are only two here, mefenide and silver sulfadiazine. Remember students, they are used for prevention of burns patients so that they don't develop any infection. Two protozoal infections where sulfonamides are useful are toxoplasmosis and plasmodial vivax. The infection which are malarial infections which are caused by toxoplasmosis, both are protozoal infections. Earlier we also used to say that pneumocystis carinii is a protozoal infection, but now its classification has fallen a little differently. So it's no longer considered a pure protozoal infection. So here we will be right if we answer toxoplasmosis and malaria. The third fill in the blanks is individuals affected with dash are particularly more prone to the toxicity of cotrimazole. It is an individual affected with who are HIV positive status, who are having acquired immune deficiency syndrome. They are more prone to the blood toxicity of cotrimazole. They are more prone to have the skin reactions more with cotrimazole. The last fill in the blank is sulfonamide useful for ulcerative colitis and rheumatoid arthritis is, students, not sulfadiazine, not sulfadoxil, not sulfamethoxazole, not silver sulfadiazine, not mefenide sodium, but sulfasalazine. Sulfasalazine, I told you, it's a drug which splits the colonic bacteria, which is split up by the colonic bacteria into aminosalicylic acid and sulfapyridine. This aminosalicylic acid will provide benefit or provide anti-inflammatory effects in this inflammatory bowel disease. So students, only this much for cotrimazole. Remember, this is asked as a short note. Sulfonamides are less asked as a short note, but cotrimazole more asked as a short note. You should know what is the basis of combination. It's one of the WHO approved fixed dose combination. What is the ratio in which it is combined? What is the single strength tablet? What is the double strength tablet? Which are the indications for which cotrimazole is a drug of choice, and what are the untoward reactions with cotrimazole? Students, for this much, so that we could at least complete the chapter. In the next sitting which we meet, we are going to talk about one important drugs which are not antibiotics. Actually, they are antimicrobial agents. They are not available from the soil fungus. They are synthetic like the sulfonamides. The name of the drugs, students, is fluoroquinolones. So keep watching, and I'm going to come with the fluoroquinolone chapter very, very soon. Thank you so much. Stay healthy. Stay comfortable in your home, as I always say. Thank you so much.